When your family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.
Good evening. Welcome to Dr. Ghosh Show. Today we have this interesting topic about trauma surgeon. Everyone must have at some point in life seen either a movie or a TV series, and especially ER, as a lot of us grew up with that, where people are rushed into the emergency and there comes this glorified surgeon who takes care of everything. And to enlighten us on that topic, we have Dr. Kaul with us. Dr. Kaul did his medical school training in Delhi, and then he came to New Jersey, where he did his training in New Jersey Medical School in general surgery, and then he went on to do trauma surgery there as a fellow, and then he stayed back as an attending, and then he moved to Hackensack University Medical Center in Hackensack, New Jersey as Associate Director of Trauma Surgery and Critical Care, Surgical Intensive Care Unit. So what does a trauma surgeon do apart from the glamour that they come and they rescue people and save people's life on day-to-day basis? What are the common things you encounter in the surgical trauma unit or through emergency room?
So trauma surgery is a specialty in the United States. It was invented in the United States, even though it's been in practice in different forms all around the world for over 100 years. Essentially, the specialty involves taking care of the sick and injured patient, soup to nuts, from the moment of arrival to the emergency room, all the way to the patient's management in the operating room by the trauma surgeon, subsequently managing the patient in the intensive care unit, and subsequently following the patient as an outpatient. So in summary, it is the management of the very severely, acutely injured patient.
Right. So not only you are a surgeon and you take care of the surgery and try to fix the problem, but you do take care of them afterwards, because they are so many times associated with other issues that you need to be one to put everything together and make sure they are stabilized to do good and finally to go home.
Sure. So a trauma surgery cannot work in isolation. Usually trauma surgeons work in those designated trauma centers in the United States, which have a pre-designated trauma team and a hospital support system, and that involves specially trained nurses, specially trained paramedics, specially trained operating rooms and intensive care units, and so that you can manage the patient. Once the patient arrives to the emergency room, a trauma code is activated based upon certain pre-designated criteria, and that is determined by how severely injured that patient is, something that is outside of the capability typically of the regular emergency room, and that may have a limbo, life-threatening situation.
So just for our viewers' benefit, I don't think, as you explained, this existed in India, and here too different hospitals have a different level of trauma care. Some can take care of really badly injured people, to some can take care, stabilize them till they are either flown to a place. So what does the designation mean in terms of what kind of patients you can take care?
So basically, trauma-related injuries are the most common causes of death between the ages of 15 and the ages of 35. It's the #1 cause of death all around the world in this population. And typically you find patients that have suffered injuries from car accidents, either as drivers or passengers, or they've been pedestrian struck from blunt trauma, or they've been assaulted by somebody, or they have suffered violent crimes like gunshot wounds or stab wounds, or they have suffered, in
a catastrophe,
some kind of a catastrophic event like an earthquake or building collapse and things like that. So when a patient like that comes to the emergency room, typically the paramedics let the hospital know that they have a severely injured trauma patient.
And this is happening as the patient is still being transported.
Correct. The patient
is
being transported in the ambulance, and the paramedics call the hospital, and the hospital activates the trauma team.
Correct.
So the trauma team assembles in the emergency room and
ready to welcome this patient.
Ready to take care of this very sick and injured patient, and in the first few minutes make an assessment of what is immediately life-threatening.
Correct.
And then the trauma surgeon has to formulate a plan that basically, at that moment in time, he has to prioritize what is likely to kill that patient first and take care of that situation right at that moment. For instance, the sequence in which this is done is typically managing the airway first, then the breathing, then any elements of his circulation like shock,
correct,
and then other disabilities and things like that. So sometimes the patient who's not stable and is having difficulties in breathing needs to be emergently intubated and placed on a respirator.
Right.
If a patient has a punctured lung, is not able to breathe, will need an emergency tube placed inside his chest. If a patient does not is in shock, may require emergency intravenous access. Sometimes the patient is so severely in shock that they will need specialized intravenous lines to be placed in the groin veins or in the upper extremity veins, or sometimes the patient is in such severe shock, if it's a baby, for instance, they'll need to have special catheters placed inside their bones,
right,
so that the intravenous fluids can be given. Once that is done, and you have bought yourself a little more time, then you create a diagnostic plan.
Right.
If that patient is in shock and you suspect that the patient has a severe head injury,
right,
then you take the patient to the CAT scanner and do radiological tests to determine what kind of head injury that patient may have, and he may need emergency surgery to evacuate that blood clot that is compressing his brain that may kill him, and you ask the neurosurgeon to meet you in the operating room. If that patient has a catastrophic abdominal injury, then you take the patient to the operating room and you perform surgery, emergency surgery in the operating room, and take care of either the bleeding problem or the intestines that have been disrupted, and you do that repair. Such type of procedures are called damage control operations. And if the patient has extremity long bone fractures and things like that, you temporarily fixate these
right,
fractures,
loose bones.
and you stabilize them by placing them in a splint or a cast, and stabilize that patient until more definitive surgery can be done.
Correct. So just listening and thinking about what happens, when you're going for a surgery which is planned, you have plenty of time to look at the surgeon, look up the hospital, look up the things, and then you make a decision. When you are in trauma, you don't know. You kind of the person that all of us put a faith in and hoping that you make the right decision. As you said, you have to, I think that split second makes so much of a difference to see which one needs to be stabilized, who gets the priority. So it really requires presence of mind and hoping that you go to the right place.
Sure. Unfortunately, a trauma surgeon is one that you hope you never meet.
I hope so.
and if you do, you hope that you're in an institution that has a great system. And a trauma surgeon is sort of the tip of the spear, and a trauma surgeon is only as good as the system a particular hospital supports.
As you rightly put, it's a group effort. So
right.
I think the most important, as you said, is the institute that you are taken,
sure.
which might make a difference, how well they are prepared for this, and how much teamwork you have. You
That's
can't
right.
do all this by yourself. You
Absolutely.
need the right person to help you out. So apart from your decision to, say, stabilize and do the ABC, making sure the airway, the breathing, the circulation is taken care of, which is the most vital thing that's going to keep that person alive.
Sure.
And then you're going to do, as you said, the evaluation, if the circulation is dropping, why it's dropping, are they bleeding internally and stuff. So sometimes you might have to do a quick diagnostic test. You don't have sometimes luxury of waiting for, normally that one would wait for, say, CAT scan with contrast. Sometimes you might have to just put in a needle and aspirate and see if they are bleeding inside, and then you make a decision.
Sure. Many times, unfortunately, we have to do emergency surgery right in the emergency room itself. For instance, if it's a young person who has suffered a stab wound to the heart.
Correct.
And has suffered a cardiac arrest. So sometimes you may have to do an emergency thoracotomy where you open the chest to obtain temporary control so that the patient doesn't die right there, and you buy a few more minutes before you take that patient to the operating room. Or if the patient is in shock and the patient may have bleeding in the abdominal cavity and you're not sure and the patient is too unstable to go to the CAT scan, you may have to do a small operation where you check to see if there's bleeding in the abdominal cavity right in the emergency room, and then make a decision whether that patient needs to go to the operating room or not. Sometimes the bleeding can be from the bones in the pelvis.
Right.
And such a patient would not benefit from going to the operating room, and so that distinction has to be made emergently in the emergency room, and that patient might need to go to angiography where the radiology doctors can, using catheters in the blood vessels, inject dye and see where the bleeding is occurring, and attempt to stop that bleeding without performing surgery.
So it's a very localized treatment at that point. Wherever that artery is bleeding, that's the one you want to stop it.
Sure.
Apart from the circulation, the breathing, as you mentioned too, a decision to put a chest tube versus if there's a pneumothorax, you need to put a needle and just let the air come out and let the person breathe. How do you make that distinction?
So the first thing is that you need to have a very highly trained team that works together. Teamwork is critical, and the experience of the trauma surgeon is essential, because you have very little time in which to make the decisions, and unless there's a very clear system in place and an experienced team, it is very easy to misdiagnose and lose precious time and have a poor outcome. So you mentioned that how do you decide whether somebody has a pneumothorax or not? And many times, if you listen to the chest, you may find that there's decreased breath sounds on the chest. It doesn't always mean that the patient has a pneumothorax, because when a patient has a breathing tube, it can be going more on the left side of the airway.
The side where the tube is.
And you can have decreased breath sounds. And so you have to factor in multiple elements in decision making. And
the kind of injury they have, sometimes that might help you make a decision as well.
So the mechanism of injury is helpful. The physical examination is very helpful, and having an organized team around you is very helpful. So typically, you have a team that's drawing bloods. You have an X-ray technician that is right there to take an X-ray immediately.
And you're monitoring the oxygenation.
And you're monitoring the oxygenation.
Right.
And then you decide. So the golden hour is critical.
Correct.
So in the first hour, time is absolutely essential, because most trauma deaths that occur, they have a bimodal peak. They occur either at the time of accident, where the patients suffer either a fatal head injury or they have exsanguinated from a major blood vessel.
And that time there's no hope. Whatever you do it has happened at the site by the time you can transfer those patients.
So after that peak incidence, the second peak incidence is in the emergency room within the first hour.
Correct.
And if the patient survived that first hour, then the other peak is a few weeks later, when they die of either infections or of multiple system organ failure and things like that.
And actually the SHIP, there was, I think it's still going on, Grey's Anatomy. There's a TV show based in Seattle, and there's so much of trauma because they're all surgeons. And there was this shipwreck, and it is so interesting how all those surgeons did like on the site work, and it's very interesting what we are discussing that was played on that show, and it's a very, very good example of how that presence of mind kind of helps people, because there were some who were drowning, some were underneath like a debris, and they had to talk to those people to keep that hope alive till they could get the trauma away, the debris away, so people could breathe, or some had to be amputated to save the people. So it was very interesting that you bring that up. We can talk about it in a few seconds. We're going to take a short break, and we'll be right back.
When your family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.
Welcome back. So far we've discussed about if you are faced with an injury which none of us plan, and it's so many times in the hands of a person you have never met at an institute that you've never been, and how much a presence of mind and teamwork can change your outcome. So now we've come to this journey that the patient has come to the ER. Your team has stabilized the patient. You made sure what is the cause of the bleeding, etc. You've done the basic workup. Now, as you said, that you can do a small procedure, see that there is a bleeding inside, and that's why this patient is not keeping up the blood pressure. And you decide to take this patient to the operating room. Take us through the journey. How do you do it? How fast you have to move? What are the common causes of this bleeding?
So the first thing that we do once we identify that the patient is in shock and has catastrophic bleeding is to make the decision that the patient is going to go to the operating room.
Right.
So I have a brief conversation with the family where I communicate what I expect and what are the chances of success.
Right.
And many times it's an unknown whether we're going to be successful or not. And we assure them that we're going to do what we need to do, and we're going to take good care of the patient. Then we take the patient to the operating room, and in the operating room, we do what we call an emergency laparotomy, where we open the abdominal cavity, and typically it is massive bleeding, and what we do what is called a damage control laparotomy.
Okay.
And in this procedure, because there's so much bleeding that's pouring out, we have the anesthesia team working behind the curtains, resuscitating the patient aggressively, and we have this entire team trying to soak up the bleeding and sucking all the blood so we can start to see what is going on in the abdominal cavity. So we basically start mobilizing the organs and identifying the blood vessels that are actively injured. And sometimes it's not as easy as it might seem. So it depends upon what the mechanism of injury is.
Correct.
So to go back to a recent case, in this instance, it was a ruptured spleen that had caused hemorrhage. So in a situation like that, we basically control the bleeding so we can identify that the spleen was injured, and we put surgical clamps across blood vessels to stop the bleeding, and we remove the spleen. In other instances where it's been gunshot wounds to the blood vessels or a knife injury to the blood vessels, we control those blood vessels using clamps and then repair the blood vessels.
Right. So, sorry to cut you off, but spleen is an organ which is not vital, so we can get away by taking out.
Sure.
But say about liver, where you can't take complete liver out, you have to stop the bleeding and somehow try to repair it, correct?
Correct. So there are different management options for different organs.
Correct.
So typically for a spleen, if it's already shattered and it's bleeding massively, the objective is to stop the bleeding so that the patient can survive.
Right.
And we do that by removing the spleen. And with a liver that has significant bleeding, what we do is we place laparotomy pads, which are like little rags inside the abdominal cavity.
And just pressure.
And apply pressure inside the liver. And usually there's so much shock that the organs swell. Right. And these patients develop what is known as abdominal compartment syndrome.
Right.
And these patients then wind up coming to the intensive care unit with essentially an open abdomen, which could not be closed, and with multiple laparotomy pads inside, and are continuously resuscitated, and have essentially an IV bag or a plastic covering over the abdominal cavity, and they're actively resuscitated in the intensive care unit until they are stabilized, until the bleeding slows down, and until their coagulopathy is corrected. Right. And then they go back for many further procedures over the next few days to weeks.
And apart from the liver injury, but there can be a lot of contamination injuries. So say with when it happened with the building collapse on September 11th, if there's so much dirt and debris, sometimes intentionally one keeps it open. Is
Yes.
that correct?
So the issue about concern about infection is secondary at the moment, because this is a relatively recent development in medicine, the recognition of abdominal compartment syndrome.
Correct.
About 20, 30 years ago, this was not recognized, and the surgeons used to attempt to fix and repair everything and close the abdominal cavity, and they discovered that many of the times these patients did not survive. So that's how the syndrome was discovered, and they learned that leaving the abdominal cavity open allowed the blood to perfuse the other organs, and the worry and risk of infection was actually less than was previously thought. Of course, you had to use good surgical technique, but you bought yourself more time in order to repair
and that swelling to go down.
And the
That's
swelling
the whole
to go
idea.
down.
Right.
So if you have an intestinal injury, many times those intestines are left in discontinuity until the patient is more stabilized in a few days, and then you can reconnect all of these things. Sometimes it's not possible to close the patient's abdominal cavity even after weeks.
Okay.
So in such instances, you allow the wound to form, and you may have to use a skin graft to cover the abdominal cavity, and these patients then come back a year later with a very large hernia, and you do what is called an abdominal wall reconstruction a year from then.
So you let it heal by secondary intention, let it just heal by itself, slowly over a
So the
period of
large
time.
wound that you have, you control that with special suction devices and whatnot, and you allow scar tissue to form.
To form over it.
Because it's such a large wound, it's not likely to heal on its own.
Completely. Strong. Right.
So because the large wounds typically go from the mid-clavicular side.
From ribs to the pelvic
From
bone.
ribs to the pelvic bones. So that's why large pieces of skin from the thigh are then taken and placed over these wounds, and you then have an intestine that is covered with human skin, like a bag, and patients are discharged with that condition that eventually forms a large hernia, which is reconstructed about a year from then.
Right. What about chest trauma? We did talk about the abdomen. Do you see like knives or gunshot which can also go through the chest or rib cage?
Sure. Unfortunately, when I was in Newark, the Knife and Gun Club was much busier than it is compared to where I am currently. But sometimes you do get penetrating chest trauma.
Correct.
So most chest trauma is usually a blunt trauma from rib fractures or bruises to the lungs, or a punctured lung from rib fractures. Sometimes you have knife wounds. I had a case a few months ago where somebody stabbed himself with 2 knives and presented to the emergency room with 2 knives sticking out of his chest up to the hilt.
Right.
And so this patient was taken emergently to the operating room. We opened his chest, and we removed the knives in the operating room and repaired the heart, and were able to close the chest, and fortunately the patient survived. Many instances, such injuries, they're not always necessarily a good outcome, particularly if they're gunshot wound injuries or the patients have lost a lot of blood before they come to the emergency room.
So you've taken care of these patients, you've stabilized them, you've taken good care of them in the ICU, and it's not only traumatic for the patient but to relatives too, just to see these big wounds and stuff. So that's where your specialty again comes in because of your expertise. How do you counsel this patient a little bit differently than, say, regular post-operative patients?
So one of the most difficult challenges in being a trauma surgeon is the challenge of communicating bad news to the family members.
Right.
And that's one of the aspects of the specialty that one has to develop, one has to spend a lot of time. And it is very challenging, and sometimes despite the best intentions, there may be bad outcomes in a severe head injury where one has to communicate death to the family, and that is very, very challenging. So what we have at my institution is that we have designated family meetings where we have communication sessions with the family, and we frequently apprise them of what is going on,
right.
and we impart the news about what is being done because it's an ongoing situation in as compassionate a manner that we can, and we develop a relationship with the family, and we go through this journey together. Right. And so it's one of the elements in this specialty where communication with the family is critical, and that bond and relationship is very critical, because we wind up being strangers when we first meet, and then wind up being very good friends at the end, and very close at the time of discharge.
You know, we talked about the trauma and the stuff, but is there something that we as population can do to prevent this? Apart from, say, stopping the drug, you know, don't drive when you're drunk, and, you know, what are the lessons that one can take home, that what we should be aware of, that we should avoid?
Sure.
And or if you are in this situation, what you should not do. As you said, you don't want to pull out that knife without being at the institute. The perfect example was the crocodile Dundee with the stingray he just took out, and that kind of made him have this mortality.
Sure.
So what are the take-home message that you have for the viewers?
So when you've, first of all, try to not have an injury. That's a big one.
Right.
Injury prevention. And so briefly touching upon that, one of the most common causes of car accidents is in young people who are driving while they're intoxicated, or who are driving while they're distracted while texting, or who are driving and they don't wear a seatbelt. I've seen innumerable instances where severe injuries could have been prevented if they just worn a seatbelt. So once, God forbid, they have an accident, they should not move, and they should call for help, because many times they may have a injury to the bones of the neck, the cervical spine injury, and so they need to be immobilized. So there's a special collar called the cervical spine collar, and they're kept on a backboard. They should ask for help, and they should receive that help by the trained paramedics that bring them to the trauma center.
We had such a nice conversation, and hopefully none of us should be in this kind of a situation, but all these things are beyond one's control at times, and if done, it gives us a very good idea about kind of why certain physicians do certain things, why sometimes they rush into things to kind of save your loved ones, and hopefully this will enlighten us about what we should not do, and wear the seatbelts, don't text while driving, and definitely don't drink and drive. Good night.
When your family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.